It is my honor to be here today to speak about a very important issue in nephrology, which is the changing picture of diabetic kidney disease. First of all, it's my honor and pleasure to participate in the Kasr Alainy Kidney Week because we consider Kasr Alainy School of Nephrology as the mother of nephrology in Egypt. And it is my pleasure and honor. I would like to thank and appreciate the kind invitation of my great friend and brother, Professor Tariq Fayyad, to give me the chance to participate in this valuable meeting. I'm going to discuss the issues of a changing picture of diabetic kidney disease under the following sectors. So I'll start with introduction, followed by changes in epidemiology and trends, clinical presentations, some pathology, important points to do biopsy or not, and what are the different aspects in doing biopsy for a diabetic patient. Then, do we need biomarkers? And before reaching the conclusion, I'll give some points in the management and the new phases in the management of diabetic kidney disease. To start with, always I like United States data system, but today I am impressed by China because they released their data on kidney disease in this special supplement of Kidney International, and executive report was released within the issue of Kidney International March 2019 as well. As you see, diabetic kidney disease is the commonest cause of chronic kidney disease, and presence of either chronic kidney disease or diabetes are associated with cardiovascular diseases, including coronary heart disease, stroke, heart failure, and atrial fibrillation. If we look at the most recent released guidelines in cardiology about preventive cardiology, presence of albuminuria exceeding 30 microgram albumin per milligram creatinine, the same 30 milligram per gram creatinine, if it exceeds this value, or the presence of lower GFR less than 60 milli per minute, this or that, are considered within diabetes specific risk factor enhancers that are independent of other risk factors in diabetes mellitus to increase cardiovascular disease. So I'm speaking about important issue, diabetic kidney disease. All nephrologists are aware with the natural history of diabetes in type 1 diabetes. So in type 1 diabetes, we have in the first phase, everything is fine, normal kidney function, normal kidney reserve. Later on, after that, hyperfiltration occurs with the nephrons are still in normal amount and volume. And after that, albuminuria starts to increase, and in the same moment, you can find here a start reduction of GFR. At the end of the disease, you'll find end-stage kidney disease. So this is the natural history of diabetes, nephropathy in type 1 diabetes, normal filtration, hyperfiltration, normal filtration phase 2, then hyperfiltration with the presence of chronic kidney disease, and then advanced end-stage kidney disease. So the tiger may have new stripes, and diabetic kidney disease have many phases of pictures. So regarding the epidemiology and trend, this data came from excellent centers all over the world. Joslin, Harvard, and Steno in Copenhagen, and Finland, and in CERN. All these are excellent centers. What do you see? There is a great variability in the incidence in 10-year cumulative risk of end-stage kidney disease, reflected by this red color. End-stage kidney disease is very high within the Joslin Center, and it's the lowest in Steno Center. In the same moment, there is variability in mortality. So it seems even in evolution of the type 1 diabetes, there is a great variability among different centers all over the world. What about type 2 diabetes? This is the largest and the biggest cohort of patients, including 421,000 patients from Finland. So it is Finland database showing the interesting data. The older the age of the patients, the lower the risk of end-stage kidney disease. And the question why? Why? Because there is increased risk of death. So this competes with the rate hazard risk of end-stage kidney disease according to the age of the patient. The highest risk for end-stage are if the type 2 diabetes is diagnosed in this age range. And the older the age, the lower the hazard risk of end-stage kidney disease, and in the same moment, the higher the risk of mortality, as you see. What about clinical presentations? This is an important article because it addressed the United States renal data system evolution in diabetes. The question of this article: have the clinical manifestations of kidney disease among adults with diabetes changed over time? And the data showed that if we look at albuminuria exceeding 30 milligram albumin per gram creatinine, what is there here? Through the years, there is reduction of albuminuria, especially in patients aged less than 65 years. In the same moment, there is increasing a percentage of patients with low GFR. So it seems that prevalence of diabetic kidney disease is the same, but has different phase, declining in albuminuria and increasing in reduction of GFR in diabetic patients. And this is the current state in the United States according to the last report. In diabetes, we have either albuminuric, this fraction, or lower GFR less than 60, or mixed both albuminuria with low GFR. Even with the United States, there is a great variability according to the race. If you look at non-Hispanic white, non-Hispanic black, and Hispanic, you can find here different prevalence. If we look at estimated GFR less than 60, or the same prevalence difference if we look at albuminuria exceeding 30 milligram per gram. This means that diabetes is different among countries and different among races. This another interesting data came from chronic renal insufficiency cohort study. Here they correlated the outcome, the risk of progression of patients with diabetes to end-stage kidney disease. So we have non-albuminuric or moderately albuminuric, higher and very high level of albuminuria. What is the risk of end-stage kidney disease? The higher the albuminuria, the higher the risk, the cumulative hazard of end-stage kidney disease. The lower the degree of albuminuria, the lower the cumulative hazard of end-stage kidney disease. To the extent that we can say for patients with normal albuminuria, the rate of progression toward end-stage kidney disease, it behaves like non-diabetic kidney disease. Another data, this is very interesting because here we have the patients with persistent to normal albuminuria. So the starting point and the end point albuminuria was normal, and this is the patients with normal albuminuria at the beginning, then it changes, progressed toward albuminuria in the beginning, and then regressed toward normal albuminuria or persistent albuminuria. The data showed that all patients can progress. So in the stage kidney disease, less than 60 ml per minute occur all through different categories, and it is highest with sustained albuminuria. Does it reflect intensive blood pressure control? Maybe, because according to ACCORD trial and according to this relatively recent publication, intensive blood pressure control in type 2 diabetes is associated with increased incidence of chronic kidney disease. So, because the relationship between systolic blood pressure and evolution of kidney dysfunction follows J-shaped curve or U-shaped curve. The higher the systolic blood pressure, the higher the incidence of kidney disease, and the lower the systolic pressure less than 120, the higher the risk also for chronic kidney disease. So it is U-shaped curve. So we should look at variability in the full context of hypertension and other factors. Let us shift to Italy. This is a large cohort of patients, 15,000 patients, and again we have normal albuminuric with normal estimated GFR, albuminuric with normal estimated GFR, normal albuminuria with reduced GFR, or both albuminuria and the reduction of estimated GFR. And the question is, what are the rate and determinants of mortality in non-albuminuric renal impairment compared with albuminuria with preserved or reduced estimated GFR? As you see clearly, this is the normal albuminuria, normal kidney function, and this is the survival, and then the presence of microalbuminuria or moderate albuminuria as it's referred by KD guidelines, the lower the survival. But even in normal albuminuric with reduced GFR, mortality is more common and survival is drastically reduced. So yes, non-albuminuria, normal albuminuric patients in diabetes carry lower risk for chronic kidney disease but higher risk for mortality. We have another term, non-proteinuric progressive diabetic kidney disease. So the risk factors for diabetic kidney disease in non-proteinuric patients include a high body mass index, high systolic and pulse pressure, and persistent hyperglycemia, all alterations triggering glomerular hyperfiltrations. And it seems that presence of diabetic kidney disease may reflect repeated minor episodes of acute kidney injury in patients with stable or slowly declining GFR, or tubular hypertrophy and tubulointerstitial damage, or other lesions. So all these factors can lead to non-proteinuric diabetic kidney disease. Let us go to another issue. The diabetic kidney disease is different from person to person according to the rate of progression or trajectory of kidney function. So, according to the categories and distribution of estimated GFR slopes in this Joslin end-stage kidney disease report cohort, we can say that we have a patient with very fast progression, moderate progression, or slow progression. How to say slow, moderate, fast, and very fast? If estimated GFR is reduced by more than 15 milli per minute per year, this is a very fast progression. What is the implication of a very fast progression? Is to have very rapid onset toward end-stage kidney disease. So end-stage develops within 2 to 5 years. In comparison to slow one, where estimated GFR reduced less than 5 milli per minute per year, and the time to development of end-stage kidney disease may reach up to 45 years. So every person has his or her unique trajectory, and this is why we should look at trajectory and try to modify this trajectory. Even in China, we may have person with diabetes with non-progressive diabetes state, or curvilinear, or linear and then curve. So every person has his unique profile of progression. This is the good news, because if we diagnose the diabetic kidney disease from early beginning and we try to start appropriate treatment, comprehensive and holistic approach for the management of diabetic kidney disease, what can happen? Even we can change this trajectory from a straight line toward the curve line. Curve line means the patient may move from fast progression toward moderate or even slow progressor if we apply appropriate treatment. And the secret of success, please don't forget that the secret of success is toward encouraging early management. So early is early and late is late. What about hemodynamics? This is a very sophisticated study addressing the GFR, infiltration, resistance within afferent and efferent arteriole. All these were measured in this study, and it gives us this figure gives us a very interesting clinical lesson. What is this? In young adults, in adolescents, and young adults in comparison to older adults with type 1 diabetes, what do you see? Here, afferent arteriole to efferent arteriole, as you see here, the efferent arteriole is not constricted. But with younger age, if the ratio is high, because there is increased resistance within efferent arteriole. Efferent arteriole constriction is clear in this age group. And this may explain that using RAS blockade earlier in type 1 diabetes may have nothing to do, because there is no increased efferent constriction in the early beginning. So even we can have lessons from advanced studies. Is microalbuminuria the earliest finding in diabetic kidney disease? This study shows data challenging the conventional wisdom on diabetic nephropathy by discussing the issue: is microalbuminuria the earliest event? And they found that low molecular weight proteinuria or non-albumin proteinuria may be the earlier markers reflecting tubular function in a diabetic patient. What about pathology? I'm not going to speak about classic pathology in diabetic kidney disease, but if you look at the data, this is the data over the years. What do you see? The diabetic glomerulosclerosis is increasing from 5.5% toward 19%, and this data carry an alarming signal toward increasing the prevalence of diabetic glomerulosclerosis among glomerular disease subtypes. Even for pathology of diabetic nephropathy, nowadays this is one of the pathological phenomena: segmental sclerosis and extracapillary hypercellularity. These two lesions may predict evolution of diabetic kidney disease toward interstitial disease. So this is the extracapillary hypercellularity, and this is the segmental sclerosis. Both of them are bad. Why? Because the higher the percentage of the segmental sclerosis and the extracapillary hypercellularity, as you see in this slide, the increase the incidence of end-stage kidney disease. And we are waiting further studies to evaluate segmental sclerosis and extracapillary hypercellularity in predicting end-stage kidney disease. A more practical question: when is the renal biopsy indicated in patients with type 2 diabetes? Because there is increasing trend toward reducing threshold of doing biopsy in diabetic patient. But we should be careful and we should be wise when to do biopsy. I agree with this view. If there is a typical presentation, a typical proteinuria, type 1 diabetes for less than 10 years, no retinopathy, nephrotic range proteinuria without progression through microalbuminuria, macroscopic hematuria, and red cell cast, all these are considered indications for doing biopsy, needless to say, after exclusion of immunological injury by doing all these tests. Last week, we have a case in our center at Urology and Nephrology Center Mansoura. This is a type 2 diabetes patient who presented with nephrotic syndrome with the absence of retinopathy. Biopsy was carried out, and light microscopic findings documented the presence of classic pathology of diabetic disease. However, when we read the details of electron microscope, we find universal effacement of thought process. So the diagnosis of minimal change disease superimposing on diabetic nephropathy was established, and we started steroid for this patient. So always, when we evaluate the biopsy, we should have all the facilities to know if there is superimposed disease or not. And this study showed that you may have the classic diabetic nephropathy pathology, either secondary basement membrane, mesangial expansion, then nodular sclerosis, and lastly global sclerosis. This is the classic pathology of diabetic nephropathy. Or we may have non-diabetic renal disease in a diabetic patient, or may have non-diabetic renal disease on top of classic diabetic nephropathy. The presence of non-diabetic renal disease may be treated. This is why 5-year renal survival is the lowest with patients with pure diabetic nephropathy, and it is relatively preserved with, and significantly preserved with, the presence of non-diabetic renal disease. So we should search for non-diabetic renal disease if there is a clue toward this pathology. This is a case of membranous nephropathy. This is the deposits within the membrane, so it's a case of membranous nephropathy in a diabetic patient. Another case here, it appears like nodular sclerosis, but electron microscope revealed fibrillary glomerulonephritis. And this is another case, diabetes with secondary basement membrane, but in the same moment, IgA superimposed on diabetic patient. More interestingly, few cases of normal albuminuria. Renal biopsy was carried out for these cases that showed variations in histopathological presentation, from nearly normal glomerulus to nodular sclerosis with minimal arteriosclerosis, with mesangial, here mesangial increase with severe arteriosclerosis. So even in normal albuminuric cases, you may find pathology. This is the largest series published up to date from Japan, showing non-proteinuric versus proteinuric phenotypes in diabetic kidney disease, with a propensity score matched analysis of a nationwide biopsy-based cohort study. This is the number of patients for the entire cohort and for propensity matched cohort. The key message is, even in non-proteinuric patients, there is pathology, but the biopsy shows less intensity of the pathology in non-proteinuric in comparison to proteinuric diabetic kidney disease. In all aspects, as you see, for the glomeruli, for the interstitial lesions, for inflammation, vascular and arteriosclerosis. Again, pathology is there even if there is non-proteinuria, but it is less intensive and less severe. More importantly, the presence of non-proteinuric diabetic kidney disease carry better outcome. So this is the non-proteinuric, and this is renal event-free survival. So the progression toward the end-stage kidney disease is less with non-proteinuric cases, and even better survival with non-proteinuric patients. The most exciting is there silent diabetic nephropathy. Yes, according to this editorial comment and on this study, this is a very interesting study. It's autopsy study for diabetic patients who died with normal urine analysis and normal creatinine. And 20 cases in this study, the biopsy revealed established diabetic nephropathy pathology in patients with normal urine analysis and normal kidney function. And this is here in autopsy, they used specimens including 100 glomeruli. This may be the reason of discovery of pathology. And the most important message came from this study is we may depend upon non-sensitive markers. So dependence on albuminuria or reduction of GFR maybe not the most sensitive markers. Do we need, and this is the patient was normal, everything is normal, and this is the classic pathology of diabetic nephropathy in this patient. Do we need biomarkers? These are the current biomarkers that can be used in diabetic kidney disease. Either markers for inflammations, like all these markers, fibrosis, angiogenesis, endothelial dysfunction biomarkers, mineral metabolism, or tubular injury markers. All these markers are, up to this moment, they are not validated for clinical use, but they are interesting research tools. Does omics, the use of omics will be the solution? For omics, we have genomics, epigenomics, metabolomics, transcriptomics, and proteomics. I don't know. Maybe in the future, they may be the only solution. And this is the data about epigenetic. And there is increasing trend toward the use of epigenetics, either for diagnostic purposes or for management of diabetes. So here, the epigenetic methylation shift will lead to alter the gene product, alter the phenotype, and then diabetic kidney disease. So it seems that this is a very nice and a growing field, epigenetic and kidney disease. Another important concept is what's known as human exosome. What is human exosome? Human exosome is a collection of endogenous genetic makeup and exogenous, either socioeconomic status, environmental, and all these factors are reflected in what is known as human exosome. Regarding the management, one of the important messages that I want to conduct within this presentation is we should be optimum, earlier management, comprehensive, intensive management of diabetes in the early beginning. What is a reflection of this? This is a study showed the legacy effect on type 2 diabetes. If you treat diabetes intensively in the early beginning, from 0 to 1 year of diagnosis of diabetes, as you see, the microvascular complication, including kidney disease, will be reduced rather than you leave the patient without optimum treatment in the first year. And so all through these years, this is from 0 to 1, 0 to 2, 0 to 3, to 0 to 4, up to 0 to 7. If you intensify the treatment in the early phase of treatment of diabetes, this will reflect better outcome on the long run. So it reduces macrovascular complication, and more importantly, the mortality of patients. This is an interesting point. And this is the current treatment of diabetes, as elegantly shown in the first session today, is treating the metabolic factors, hemodynamic factors, by using these drugs. And now there is an increasing trend toward the sophisticated pathophysiology. So we have apoptosis signal regulating kinase inhibitors, and we may have inhibitors of the epigenetics, pathophysiology. All these may be in the future, and they are tested in the preclinical phases. Is it the inflammation? And we should focus on inflammation, because, as I mentioned, the inflammatory pathway is one of important pathogenetic mechanisms for type 2 diabetes. So we have all these drugs that were tested, and their results are appealing, and there are ongoing trials. We are waiting the results of the ongoing trials. One of interesting issue. Today we discussed the value of the use of sodium glucose cotransporter 2 inhibitors in changing the outcome of diabetes. Okay? But what about sodium glucose cotransporter 1? This is a very recent study, showed a very interesting data. If we block sodium glucose cotransporter 2 by using sodium glucose cotransporter 2 inhibitors, we have sodium glucose cotransporter 1 within macula densa. So this cotransporter will be activated, and when it is activated and highly expressed, it will lead to increased nitric oxide synthase expression, and this will end in TGF reduction of TGF vasoconstrictor tone, tubuloglobulin feedback control, with resultant hyperfiltration. So, stimulation of sodium glucose cotransporter 1, either directly or indirectly, so nitric oxide synthase, can attenuate tubuloglobulin feedback. What is the benefit of knowing this information? In the future, maybe the solution is to target sodium glucose cotransporter 1 besides sodium glucose cotransporter 2, or to target nitric oxide synthase gene expression. To conclude this presentation, always in the past there was a dogma: once diabetes, always diabetes. Even diabetic kidney disease, I have a lot of data about the reversibility of diabetic kidney disease, and one of the pathophysiology is reduction of autophagy. This is why we have this thesis of Dr. Summer. I was the principal supervisor of her thesis. So we have studied the impact of induction of autophagy on natural history of diabetic nephropathy in rats. And it was our honor to have the greatest star of nephrology in Egypt and even in all over the world, Professor Barsoum, who discussed this thesis on March 10th this year. And in this experiment, we here, this is the established diabetic kidney disease after induction of diabetes. As you see here, the basal membrane is very thickened. This shows the pathology of diabetic nephropathy. And LSS3, which is the marker of autophagy, is reduced. And after induction of autophagy by the use of mTOR inhibitors and metformin, as you see, LSS3 is expressed. And the most important here, the basal membrane regressed. So again, diabetic kidney disease is amenable to regression. So it is not only progressive. In the future, it may be that we will witness a great evolution in diagnosis in all these aspects: biology, personal characteristics, social environment, environmental factors. So when we know these factors that affect individual person, we can select the best treatment for the best treatment in the best moment, and this is the only guarantee for the success of management of diabetes, and this is considered as personalized medicine. And one of the important issues to be followed when we treat the patient is to follow the team approach, and this is what I learned when I joined this team in the early 90s. And here all these are the nephrology team at the Urology Nephrology Center, and this is Professor Ghunaim, where we celebrated yesterday by completion of 3,040 cases of live donor kidney transplantation, and the majority of them were related donor kidney transplantation. I am a great believer in education. This is why I am proud of this site. And again, a doctor is a student until he dies. Once he considers himself not a student anymore, the doctor inside him dies. And thank you for